I just want to say again, thanks, to Debbie's Dream Foundation for all the tremendous work that Debbie and her colleagues have done, and it's been a privilege to have been involved in the advocacy efforts this year. These putting a face on a disease really makes a difference, and I encourage patients, families, caregivers to consider contributing to the advocacy efforts as well as the educational and other programs. So I think Adam covered a fair amount of what I'm going to talk about already, so I think, but I'm charged to talk about clinical trials. So sometimes patients think, oh, a clinical trial, I'm a guinea pig, is this really going to help me? Should I just get standard treatment? But clinical trials are really how we developed all therapies in cancer treatment. We sort of have to establish, does treatment A work better than treatment B? Do adding new therapies improve outcomes? Just because something is new doesn't mean it's better. In fact, that's why we have to do controlled studies. Sometimes new treatments turn out to be harmful rather than beneficial. So the goal of clinical trials is really to try and identify new treatments and improve upon standards of care. So I'm briefly going to discuss different phases of trial and drug development. And there are nuances to different studies, but I'll try and keep it as general as possible. So phase 1 trials often have a bad rap, certainly in the patient advocacy community, because often phase 1 studies are really evaluating a new drug. I mean, something that just hasn't been tested before, or potentially a new drug combination, putting together drugs that haven't been combined before, so you need to really establish whether it's safe to do that. So phase 1 studies also are not only done to establish whether a new treatment is safe, and to also figure out how to dose the new drug, but to also get some signal of benefit. Do we see some benefit in a patient getting the new drug? Because oftentimes drugs that are put into phase 1 clinical trials are things that have been screened in the laboratory and in animal models, and these are drugs that we think should work, but before really doing formal, more extensive studies, we have to establish whether or not it's safe to give a new drug to a patient and what's the dose. So usually the first part of a phase 1 trial is to really treat a defined group of patients with a dose of a new drug, and the doses are typically increased because we usually start at a very low dose of the drug because these are often things that have never been tested in patients. So we usually start at a very low dose, and then we escalate or increase the dosing that's delivered in groups of patients. So typically 3 patients would get 1 dose of the drug, and if it's safe, then the dose is raised, and then there's another group of patients that's treated. And the trial ends when a safe dose level is established. We figured out, what's the safe dose? Are the side effects tolerable? Also, when patients are on phase 1 trials, we get blood tests to figure out how the drug is cleared and how also that helps investigators figure out, should we give the drug once a week? Should we give it daily? Can we give it once every 3 weeks? So that really is the initial part of phase 1 drug development. There's a new aspect of phase 1 drug development now, which is called expansion cohorts. So once in a phase 1 trial we establish what's the right dose to give to patients, then often the trial will identify, let's say, patients with gastric cancer or breast cancer, to treat specifically a group of those patients to see whether or not there is some signal of benefit. And phase 1 trials are most often appropriate when pretty much we've tried all conventional treatments. We've gone through the standard chemotherapies and they've stopped working, and we don't really have another good option, because it may be difficult to accept, but sometimes we just don't have another good option. We have maybe 3 or 4 lines of chemotherapy that we can use, but then the next step is, well, we just don't have a good option. Phase 1 trials are often appropriate, I think, in the later phase of patients' illness when they have really not responding to conventional treatments anymore, and then we really need to try something new. But another wrinkle of phase 1 trials is combinations of established treatments. So sometimes we might be trying to take an established treatment and add a new drug. So that's also a phase 1 trial because you're trying to establish what's the safe dose. So it actually, in some cases, a phase 1 trial might be your best option. You know, if you're getting a standard upfront conventional treatment and adding an exciting new drug, that might be a high priority as opposed to a treatment that you would get later on in the illness. So phase 2 trials, these are a little bit more defined. So we now have a new agent and we know how to give it. We know it can be given at a certain dose, once a week or every 3 weeks or whatever. And phase 2 trials are really to try and evaluate a new drug in a defined group of patients. So phase 2 trials typically, phase 1 trials are often open to all different cancers. You know, we could offer a phase 1 drug to patients with many different types of cancers. Phase 2 trials really focus on a specific disease because you want to see whether or not the drug has effectiveness in that particular cancer. So these are often single-arm studies. Everybody gets the same treatment. Usually the trial is, you treat a fixed number of patients and you want to see a certain degree of effectiveness, you know, how many patients respond. And if you get, usually it's a 20% threshold of response, then that justifies to take that trial to further study. There are some phase 2 designs that are actually randomized trials where there are multiple arms in the study. So, and basically randomized phase 2 trials, you can't really compare the treatments because they're small studies. It's more often to see maybe different schedules of the same treatment, and you're trying to figure out what's the winner, what's the better tolerated of the two schedules. So, but typically phase 2 trials are focused on one disease. You treat a finite group of patients to see whether or not you get a signal of benefit that justifies taking that treatment further. Now, phase 3 trials, these are the ones that really establish standards of care. So typically, phase 3 trials will combine a new or a modified therapy to a standard of care. It may involve adding a new drug to standard therapy. And these are the large multicenter studies that are done throughout the United States. Sometimes these are international trials, particularly for a disease like gastric cancer, which is a lot more common in Asia. Increasingly, we're seeing international efforts to study new drugs around the world rather than just studying them in the United States and Canada. So what about placebo? So that often is a difficult concept to understand, and understandably. I mean, I think patient advocates would say, well, you know, I'm going on a trial to get a new treatment. Why would I ever want to get a placebo, which essentially is not getting any treatment at all? Well, placebo-controlled trials are appropriate when the actual standard of care is no treatment. So suppose the standard of care is really to do nothing else. So, and you really need to define whether or not the new drug that you're going to add has benefit, then a placebo would be placebo just means standard of supportive care with no active treatment. So in some trials, a placebo is appropriate. Sometimes, let's say for a preventive treatment after surgery, patients have gone through surgery, chemotherapy, and radiation, and they've finished all their treatment. So then we want to look at a new preventive treatment. So that might be a placebo-controlled trial. The standard of care is to do nothing else, and the new treatment is to introduce a new therapy. So now I think in more later stages of cancer, when patients, you know, have gone through established treatments, it's a lot more difficult to accept just to getting a placebo, that you really want to get treatment. So oftentimes in those trial designs, what will happen is if the patients that are getting the placebo and their tumor grows, then they can cross over to the active treatment. So many of the placebo-controlled trials in later phases of cancer treatment often have a crossover, so it gives the patient the option to get access to the new drug if the cancer progresses. And another issue is blinding, because sometimes some of these studies are looking at, does the patient feel better on the treatment? What's the quality of life of the patient? Do they feel better on the treatment? And if the doctor knows what treatment you're getting, that could introduce a bias, because most of us, we have a new treatment, and the new treatment has to be better. So, you come bounding into the room and you're really happy, and, there might be a bias that if you know what treatment the patient's getting, you might not get an accurate understanding of what the benefits are. So I mean, the placebo and blinding, they're all scary terms, but they make sense if you think about it. So I just want to talk a little bit about staging of gastric cancer. There were a number of questions about this earlier. Typically, the first step is to do an endoscopy and get a biopsy. You don't have cancer until you have tissue proving you have cancer. Typically, all patients should get a CAT scan. I think that's the initial staging technique to look to see whether the cancer has traveled somewhere else. If the cancer does seem to be localized, we typically also do endoscopy with ultrasound because that will establish how locally advanced the cancer is and whether or not we see local lymph nodes. And then depending on how superficial the cancer is, the surgical speaker earlier mentioned that for very superficial cancers, we can sometimes treat them with endoscopy. You don't even have to have surgery. The gastroenterologist goes in and just cuts out the tumor endoscopically, and depending on the pathology, that may be all that's necessary. I wish I could say that that was more of a common option in the West, but because we don't screen for gastric cancer, we don't find these early cancers. But certainly in Asia, where they have mass, gastric cancer in Japan is the most common cancer. So patients get screened and they find these early cancers, and sometimes they can be treated endoscopically. So for tumors that are invading into the muscle, which we call T2, typically this is someone that we would probably send right to surgery. We would probably not give any additional treatment. But then when the tumor's going through the wall of the stomach, or we see lymph nodes on the CAT scan or the endoscopic ultrasound, these are the patients that we would want to do a laparoscopy prior to proceeding to surgery. Because it turns out that patients that have a T3 or a node-positive cancer, if you do a laparoscopy, about 20 to 30% of the time, you're going to find small cancer deposits in the lining of the abdomen, and that makes a patient stage 4, and really surgery is not helpful. So laparoscopy should be done. And also for these T3 or node-positive patients, these are the patients that we would consider for additional treatment added to surgery, either pre-operative chemotherapy or a consideration for chemotherapy with or without radiation after surgery. So we have clearly made modest advances in the surgical management of gastric cancer in that adjuvant therapy, so any treatment added to surgery does improve survival. So we know for patients that have stage 2 or 3 disease that we should do something more than surgery alone. And we have a number of different options that have been validated by clinical trials. And again, phase 3 clinical trials. And actually, all of the studies that I've listed here compared active treatment versus observation. So all of these studies were phase 3 randomized trials in which the standard treatment arm was surgery alone without additional treatments. So Dr. Willett discussed earlier the US approach. This was actually one of the first positive trials of preventive treatment after surgery in gastric cancer, where patients got surgery first, and then they got postoperative 5-FU and radiation. And this study improved survival. This study has been updated many times, but it was a modest improvement. It was certainly not a home run. It was a modest improvement, about a 10% improvement in 5-year survival compared to surgery alone. Now, one of the problems with this study is in the US, where a lot of surgeries are done in the community, and a lot of surgeons treat a lot of different cancers. They don't specialize in gastric cancer, as opposed to Japan and Korea, where they might operate on 20 patients a week. Even in the US at major cancer centers, we don't see nearly the number of patients that our Asian colleagues do. So in the American trial, surgery probably was not as good as it should have been. The majority of patients had what we call less than a D1, D2 resection. Relatively low numbers of lymph nodes were taken out at the time of surgery. And the biggest impact of radiation on this trial was actually to reduce local recurrence. So many question, if we did a better surgery, maybe everybody doesn't need radiation. So then the next positive study came from Great Britain, where patients got preoperative chemotherapy, surgery, and then postoperative chemotherapy, and that was compared to surgery alone. And even without radiation, chemotherapy before and after surgery also improves survival, but again, a modest benefit, 13% better than surgery alone. Now, in the surgical management, I was a little bit harsh about epirubicin earlier. I wouldn't give epirubicin in stage 4 disease, but epirubicin, at least at the current time, does have a role in the perioperative setting. So ECF we would give before and after surgery, although there are data that question even that, but we won't get into that. And now in Asia, surgeons rule in Asia. Surgeons call the shots. In fact, in Japan, surgeons give chemotherapy. And there are cultural issues. I remember having dinner once in Tokyo with one of the leading gastric cancer surgeons in Japan, and we're talking about different adjuvant approaches, and my surgical colleague said, well, we just don't think it's ethical to delay the surgery, that you got to get that surgery and then give the chemotherapy later. So the predominant approach in Japan is to do surgery up front and then give chemotherapy. And there are 2 large trials from Asia that also show that postoperative chemotherapy is beneficial. So, and again, you can see that repeating statistic, whether you give oral 5-FU for a year or you give capecitabine and oxaliplatin for 6 months, again, you get about a 10% improvement in survival. So adding chemotherapy to surgery improves outcome, whether you get it before or after surgery. The role of radiation may help node-positive disease, but probably has less of an impact if you do higher quality surgery. So what about metastatic gastric cancer? So we do have modestly active chemotherapy. I've kind of included the whole laundry list of chemotherapy regimens here. If you kind of focus on the middle of the slide, we look at the number of patients. These are large randomized trials treating anywhere from 100 patients to up to 400 or 500 patients. And you can see the response to chemotherapy in the middle. So the response to chemotherapy, it's around 40%. So that means 40% of patients are going to have major shrinkage of their cancers with chemotherapy. And that they're typically time to progression, TTP, means how long are they going to be on that chemotherapy? It's usually about 6 months. And survival statistics are around 10 months to a year. And that's an average. So that's an average. So whenever anybody talks to you about, what's the survival of chemotherapy, it's an average. So that means half of the patients do better. So I always try and focus on the half of the patients that do better. So don't be scared by statistics, because that's an average. And as I said, everybody writes their own book, and there are patients that do better, clearly do better than the average. But the point is that chemotherapy is modestly effective. It's modestly effective. 2 drug regimens, treatments like Folfox and capecitabine, oxaliplatin, cisplatin, probably have the same effectiveness as 3-drug chemotherapy. When you add the 3rd drug, drugs like epirubicin, and you add a taxane, you get a lot more side effects and not clear benefits. So Dr. Bass just talked about targeted therapies, because it's clear that conventional chemotherapy, I just showed you the results, has limited benefit. It clearly does help patients, but its benefits are limited. So we've now tried to become more specific in looking at how cancers grow and progress by looking at targeted therapies, really attempting to block much more specific pathways in the cancer that drive cancer growth. And Dr. Bass said, we're trying to characterize cancers to really identify what drivers drive what cancer. Because chemotherapy is really a non-specific treatment. It's basically toxic to tissue. It doesn't really focus on specific pathways. And the targeted therapies that are being looked at include a number of different drug categories. Monoclonal antibodies, these are generally large molecules. They don't get into the cell, and they basically block things on the surface of the cancer cell. So they may block a receptor on the cancer cell. They may block a molecule that activates a receptor, but monoclonal antibodies sort of stay outside of the cell, and they block receptor pathways. Tyrosine kinase inhibitors, the way that these receptors work and the way that these receptors stimulate growth in cancer cells is almost always through an enzyme called tyrosine kinase. So there's a series of tyrosine kinases that get activated in the cancer cell, and we have developed tyrosine kinase inhibitors. So these are drugs that get into the cell and shut down the tyrosine kinase and may block the growth pathway. Then there are soluble receptors to growth factors. There's a drug called aflibercept that's used in colon cancer. And then there are other pathway inhibitors downstream. How do we affect protein and other metabolic pathways in the cancer cell? So there are a number of different drug categories to try and specifically target growth-promoting pathways in cancers. So Dr. Bass talked about this. There's a lot of different ways that you can do genomic profiling, and it's not that easy. One is to look at messenger RNA. So the DNA is what it codes the genomic information, but then from the DNA, you've got to have a way to transcribe it so that you can make proteins. And the transcribing mechanism is messenger RNA. So we can look at levels of messenger RNA, that tells you how the gene is expressed. We can also look at broad DNA array panels. This to me is always the most confusing because it looks at thousands of genes, and you kind of get these printouts of, red genes are overexpressed and green genes are downregulated. And it has been helpful in some cancers to look at prognosis, but the problem is it's just kind of a blur. You're looking at thousands of genes, and you're really not identifying one particular target. Now, one of the contributions that Dr. Bass's lab has made is you just sequence the whole gene, sequence the whole genome, looking for abnormalities, looking for mutations, amplifications, how genes are activated or turned off. Then there are these more old-fashioned methods. FISH, this looks at one particular gene. This is done in HER2 testing. We can actually count the copies of the gene in cells by doing FISH testing. And another old-fashioned technology is the pathologist does stains on the tissue. Immunohistochemistry, they're staining the tissue for protein. That also is standard for doing HER2 testing. But the old-fashioned immunohistochemistry, protein expression, the old-fashioned FISH testing are rapidly being supplemented by this whole genomic sequencing to get an idea of the entire spectrum of mutations and gene amplifications across the entire cancer genome. So these are actually data from one of Dr. Bass's papers. This was one of the early publications from their group. So they're looking for mutations in gastric cancer. So, and as Dr. Bass said earlier, it probably is more gene amplifications than gene mutations in gastric cancer. And from one of their early studies, they did identify that there were two commonly mutated genes that are activated. One is called cyclin-dependent kinase, and another is PI3 kinase. So now, what we mean by activating mutations is that when these genes are affected, they're turned on. They're super active. And there actually are drugs in development to target these activated genes. Then below that list, I've got three commonly seen tumor suppressor genes. Tumor suppressor genes are harder to develop drugs because it's easy. If you've got the light switch turned on, and you want to turn the light switch off, you want to develop a drug that's going to turn the light switch off. Tumor suppressor genes, you've lost the gene. So, because Dr. Bass talked about pushing the foot on the gas, to accelerate the cancer growth, that's an activating mutation. You're pushing the foot on the gas. Tumor suppressor genes put the foot on the brake. So a tumor suppressor gene is a brake on the cancer. So if you lose the tumor suppressor gene, you take the foot off the brake. So how are you going to replace it? You have to put the protein back, and that's easier said than done. So tumor suppressor genes are lost. So it's kind of hard to target them for drug development because the way that you would try and overcome would be to reintroduce the protein, to put it back in the cancer cell. And probably the most common one is P53. And P53 mutations are seen in about 50% of gastric cancers, but it's not targetable because you lose the function, so you can't, you'd have to replace P53 to put it back, to get it activated again. And this is actually one of the problems with the genomic profiling that we're doing, as Dr. Bass alluded to. We get all this information about the mutations and the abnormalities in the cancer, but we don't know how to use the information. And P53 mutation, which we see all the time, we don't have any drugs to treat it. So Dr. Bass talked about gene amplification. This seems to be more important. And I've listed, there are 5 common amplified genes that we see in about 40% of gastric cancer. These include EGFR, HER2, the MET pathway, FGF. So those are 4 potentially targetable pathways that have amplified genes. And then Dr. Bass talked about the subsets. So based on their genome atlas work, they identified 4 subsets of upper GI cancers. I'm not going to get into the details, but it may be that there are different features of these subsets that we can design specific studies for the different subsets because they have different mutations and different pathways affected. And in terms of immunotherapy, it does seem that PD-L1 and PD-L2, those are potential markers for activity of the immune drugs. So in cancers that have high levels of PD-L1 and PD-L2, the immune pathways may be more susceptible and more targetable. And in the slide here, if you look at the panel on the left, it looks like the EBV and the MSI high tumors have the highest level of PD-L1 expression. And you look at the panel on the right and look who has the highest level of expression. Again, it's the EBV and MSI. So those 2 subtypes of gastric cancer, EBV and MSI, may be better candidates for immunotherapy because they have the high expression of the marker in the tissue that may identify a better response to immunotherapies, but we still don't know. But what the data that Dr. Bass's group is generating will help us test the hypothesis. Is it really these patients that are going to benefit? So at least we have an understanding potentially of the biology, right? Rather than just treating everybody and seeing what happens, we can look and see if there are particular markers that might identify which patients are going to benefit and who won't benefit. So just to, I know I'm running to the end of my time, just to review some of the successes and failures of targeted therapies. So the EGFR, that's one of the 4 commonly amplified pathways in gastric cancer, but the drugs don't work. A number of trials have been done adding EGFR targeted therapies to chemotherapy, and they all did not succeed. And these include trials of panitumumab from Great Britain, cetuximab from continental Europe, and there was a large trial of gefitinib, which is a tyrosine kinase inhibitor for the EGF receptor, and none of these studies improved outcome. So EGFR to date is just not a viable target. We need to figure out, okay, it's amplified, but there's probably something else going on that we need to do to really make this a viable target. So currently available EGFR drugs have no role in the treatment of gastric cancer. So HER2 has been the big success story. HER2 is amplified in about 20 to 30% of gastric cancers. The HER2 receptor is part of 4 other receptor family, and these receptors interact. So although we target HER2 with the drug trastuzumab, we can also target other family members. We can target HER3 with a new drug called pertuzumab. And we're really following the lead from breast cancer because this is really where the HER2 story was developed. And a lot of the drugs that were developed in breast cancer are now being studied in gastric cancer. And I just want to show you how complicated this is. So there's the HER2 receptor. This is a picture of a cell. So that's the cell membrane, that blue stripes. And then the HER2 receptor is on the outside, but then look at the inside of the cell. Look how complicated that is, all those downstream pathways. So that's both, makes it confusing, but it's also a blessing because it gives us a lot of potential other opportunities to add other drugs to Herceptin that might inhibit that pathway. So you can see it's very complicated downstream pathways. A lot of these are tyrosine kinases that can be targeted by new drugs. So the HER2 story was successful. Again, this is a randomized trial. We talked about randomized trials. And this was a trial in HER2-positive gastric cancer. And this was a pretty ambitious effort, because remember, only 20% of patients are HER2 positive, so they had to screen nearly 4,000 patients to identify 600 patients that they could put on the study. And then they flipped a coin, and half of the patients got conventional chemotherapy alone, and half of the patients got chemotherapy plus Herceptin. And this was a positive study. There was improvement in survival. You can see the HER2 arm on the top. The red arm had better survival than the blue arm. Now, it is a modest benefit, but how we make progress in cancer treatments is we make one step at a time. So we add a few months of benefit from one treatment, then a few months of benefit from the next treatment, and a few months of benefit from the next treatment. And all of these incremental benefits add up to improving outcomes. So there's small differences, but significant. So survival was improved with the addition of Herceptin. And if you really had strong expression of HER2, you even did better. You can see that there's even a better survival benefit for patients that had high levels of HER2 expression. Now, that doesn't mean that all HER2-targeted drugs are going to work, because gastric cancer is not completely analogous to breast cancer. And this was a trial that looked at the drug lapatinib. Now, lapatinib is an active HER2 drug in HER2-positive breast cancer. And this was a study looking at initial chemotherapy with or without lapatinib. So these were HER2-positive patients assigned to chemotherapy alone versus chemotherapy plus lapatinib. And it does seem that the black curve did improve a little bit initially, but overall, there wasn't a big enough benefit to say lapatinib really improved outcome. It's interesting, this was a global trial, so it was run in Asia and the United States, and actually the patients that were treated in Asia had a benefit from lapatinib. So patients that were treated in the West, we didn't see a clear benefit for adding lapatinib, unlike the results with Herceptin. So there are ongoing trials of HER2-targeted therapy in gastric cancer. The one that we're waiting for most anxiously is the JACOB trial. So for HER2-positive patients with gastric cancer, chemotherapy plus Herceptin or trastuzumab is the standard. And this trial is looking at adding another drug, pertuzumab, so it's double targeted HER2 therapy, trastuzumab alone or trastuzumab plus pertuzumab. And this study, I think, has completed accrual. You can see a big phase 3 trial, 780 patients. And a lot of us expect this to be positive because pertuzumab and trastuzumab work very well in HER2-positive breast cancer. And this may establish a new standard of care. If this is positive, then we'll be giving patients that are HER2-positive 2 drugs, Herceptin and pertuzumab, in first-line treatment. Another trial, this was done in second line. So these are patients that were getting Herceptin already and it stopped working. And then we looked at a drug called TDM1. This was another promising drug from breast cancer trials. So this was a trial comparing Taxol versus TDM1, and TDM1 wasn't any better. So it's probably not going to get approved because it wasn't any better than conventional chemotherapy alone. It was a pretty big disappointment because this is an active drug in breast cancer, and it really emphasizes that, again, although gastric and breast cancers both have HER2 as an important pathway, they don't always behave the same way when you give patients the drugs. So Chris Willett mentioned earlier combining Herceptin with radiation. This is a recently completed study in the United States called RTOG 1010. These are patients more with esophagus and gastroesophageal cancers in the junction between the esophagus and the stomach. Here we routinely give with radiation with chemotherapy. And again, a randomized trial, so randomized trials are important. So you have to compare a standard arm to a standard arm plus a new treatment. So on this trial, HER2-positive esophagus and GE junction cancers, everybody got chemotherapy and radiation, which is standard, and then half of the patients got the addition of Herceptin, and the other half of the patients didn't. So This trial has completed, and hopefully let's see whether adding Herceptin in the curative setting in locally advanced disease, whether it improves outcome compared to chemotherapy and radiation alone. Another pathway I'm going to talk about briefly is MET. This is another pathway on the surface of the cancer that's amplified in about 10% of gastric cancers. The problem is there were 2 big randomized trials looking at 2 different drugs, and they both failed. So unfortunately, MET to date, like the EGFR pathway, MET not moving forward at the current time. 2 randomized trials, adding a MET-targeted drug to chemotherapy did not improve outcome compared to chemotherapy alone. And then the last pathway I'll mention is FGF receptor. This is another amplified pathway in about 10% of gastric cancers. There are drugs in development to target this pathway, including drugs like nintedanib and davitinib. Some of them are looking at the drugs alone or in combination with chemotherapy, and some of the trials are actually only putting patients on the study if they have an activating mutation in the pathway. So really, except for HER2, there's no identified biomarker for gastric cancer, and recent trials of EGFR drugs and drugs like Avastin did not work. However, angiogenesis is now being revisited with some new trial data. Although bevacizumab or Avastin did not help when added to first-line chemotherapy, a number of drugs are now positive that target angiogenesis that improve outcome in gastric cancer. I'm going to mention ipatinib briefly. Ipatinib is a tyrosine kinase inhibitor developed in China, and they reported recently a randomized trial in gastric cancer after patients had gotten all chemotherapies and nothing else worked. And here you see it was placebo. It was a placebo-controlled trial because patients had really, at this point in their disease, the standard treatment is no further treatment. So, but they kind of stacked the deck so that more patients could get the new drug. They randomized 2 to 1, so twice as many patients got ipatinib versus placebo. But placebo, again, is appropriate because there's no other treatment at this point. And you can see, again, that there was a modest survival benefit for ipatinib. So not a huge difference, but a modest improvement in survival. So this drug is now actually approved in China, and there will likely be studies in the United States of this drug, but again, modestly effective. So I think the drug that's available in the United States is ramucirumab. This is now approved for metastatic gastric cancer. 2 pivotal trials that showed survival benefit for combining this drug with chemotherapy or giving it by itself. This was the REGARD trial. These were patients that had progression of their cancer on the first chemotherapy, and then they were assigned to get observation or ramucirumab, and modest improvements in survival and progression-free survival. So this was a well-tolerated drug. So based on these data, the FDA approved ramucirumab even by itself to treat patients. But as Dr. Ajani said, ramucirumab by itself doesn't have that much effectiveness, and I think the more clinically relevant use is combining it with chemotherapy. So this is the second positive trial for ramucirumab, the RAINBOW trial. This looked at patients that were progressing on treatments like Folfox, and then as a secondary treatment, they would get Taxol. So this looked at Taxol alone with or without ramucirumab, and this showed a significant survival benefit for adding ramucirumab. It actually achieved one of the best survival numbers for second-line treatment. So based on these data, ramucirumab is approved by itself and for combination with Taxol in second-line treatment. And it also improved response as well, nearly a doubling of the response rate. So improved response rate, progression-free, and overall survival, and it's generally a pretty well-tolerated drug to add to chemotherapy. So I know Adam talked about this a little bit, so I'm just going to go over some of the trial data. Immunotherapy studies now, we're not trying to really stimulate the immune system, but we're trying to shut off the suppression of the immune system that cancers create. Because we think, for years and years and years, we looked at vaccines and immunostimulants, and they didn't work. And it wasn't until we realized that the cancer cell is really inhibiting the immune response, so what we need to do is shut off that inhibition. And we essentially are blocking the immune checkpoints to allow the immune response to become active. Now, this is an interesting slide because this looks at all different types of solid tumors. So, and this looks at how many mutations are present in the cancer. So on the left side of the curve, those are cancers that have very few mutations. On the right side of the curve are cancers that have lots and lots and lots of mutations. And you'll notice that at the top of the list is melanoma and lung cancer. Melanoma and lung cancer, immunotherapy works quite vigorously, and there's a number of immunotherapy drugs approved, and we think part of it is because these cancers present a lot of stimulation to the immune system so that these drugs work better. Now, what's highlighted in the blue, that's stomach cancer. So stomach cancer is in the upper tier. It has a fair number of mutations, so it's certainly better than the average. So stomach cancer probably is a reasonable target disease for immunotherapies because it has a fair number of mutations. It's not melanoma, but there are many mutations present. And then I showed you this slide earlier. Are there subsets of gastric cancer that might potentially better benefit? And the subsets include the EBV and the MSI patients, which account for about 30% of patients that might be better candidates for immunotherapy. So what are the data? Kind of mixed, not a home run yet. CTLA-4, this was the first generation of drugs. These are a lot more toxic than the PD-1 drugs. Here's a trial of a drug called tremelimumab, and you can see it only induced one response in 18 patients. So only one responder in 18 patients, so at that time they did not take this drug further. Here's a PD-L1 drug called MEDI4736. If you look at the right-hand side of the curve and you see those blue bars, so anything on the bottom are the people that responded. So not a lot of responses. It's about 7%. So about a 7% response for this particular drug. Here's another anti-PD-L1 drug. This was one gastric cancer treated and one gastric cancer responded, so 1 out of 1. So the most mature data come from the drug Keytruda or pembrolizumab. This is the Merck anti-PD-1 drug. They have presented these data many times in gastric cancer, looking at treating advanced gastric cancer with this pembrolizumab drug at various schedules. Now, what was different about this trial is that they looked for a marker of benefit. So you had to express the marker in the tissue. You had to have expression of that PD-1 protein in order to go, PD-L1 protein, in order to go on the study. And it turned out that 40% of patients had positive testing. So the response rate's about 22%. Here's that waterfall plot again. So anything below the curve, those are people that had some response. So that's a lot more impressive than what you saw earlier. So about 50% of patients had some benefit from this drug. And what this shows, this is the duration of benefit, and the little red arrows, that means that the benefit is still ongoing. So about half of the responses were durable, that people were still responding to this drug 6 or 12 months into treatment. So a very promising signal of activity. So what are the other pembrolizumab trials ongoing? There's Keynote-59 and now Keynote-62. This was a trial looking at first-line combination of pembrolizumab with chemo and looking at pembrolizumab as a late-line treatment. This has now been succeeded by Keynote-62, which is comparing head-to-head pembrolizumab versus chemo. So they're giving the immunotherapy as initial treatment for metastatic gastric cancer, and this is in patients that are PD-L1 positive, that have the marker that may indicate they respond. The other trial they're looking at is second-line treatment. So these are patients that have had progression of their cancer on FOLFOX or 5-FU platinum. It's a 720-patient trial. They're comparing Taxol versus pembrolizumab. You could argue that the control arm should really be Taxol plus ramucirumab, because the ramucirumab is now approved. So I'm not sure how we're going to interpret this study, because most patients wouldn't give somebody Taxol alone. At this point, we'd give them Taxol plus ramucirumab. But this basically is looking at pembrolizumab versus chemotherapy as a secondary treatment. And then Dr. Bass also mentioned nivolumab. This is the other PD-1 drug from Bristol Myers. These were data presented a few months ago at the GI Symposium. They looked at 58 patients with gastric and GE junction cancers. Now, in this trial, there was no selection. They didn't look for a marker, so they treated anybody. And they had responses of about 12%, so a small degree of activity. 40% had positive finding of the marker, but they saw responses in both the marker positive and the marker negative patients. So it doesn't mean that this PD-L1 has to be tested. I mean, maybe you can respond to this drug whether you're PD-L1 positive or negative. So I've tried to cover a lot of territory. We've talked about clinical trial design. We've talked about what pathways seem to be promising. We've talked about mutations and genomic profiling. We've talked about immunotherapy. So it is an exciting time in new drug development. But again, all these little benefits, these little incremental benefits add up. So we are making progress, and obviously funding and advocating that our government supports cancer research is your purview today here as patients, caregivers, and patient advocates. So for clinical trials may be appropriate at any stage of your gastric cancer treatment. They're evaluating the safety and benefit of new therapies compared to standard therapies, and informed consent. Read the consent form, see what you're getting yourself into. It has to be clearly explained to you what are the risks and benefits of a new therapy. Targeted agents, outside of HER2, we've not had success with other pathways. We now have Herceptin approved for use, and we await the results of pertuzumab. Other pathways have not been successful, including MET and EGFR. For angiogenesis, we have the use of ramucirumab now in second-line treatment. Immunotherapy is a work in progress. I showed you that it does seem that a small subset of patients may benefit. There is a promise for a number of these drugs having response rates of 10 to 20%. And what's the marker? How can we identify which patients are going to benefit? It may be that this PD-L1 expression is useful. And then I talked about the two subsets of gastric cancer that may be good candidates for these new drugs. And thanks very much.
Thank you so much, Dr. Ilson.